Hello and welcome to a special webcast of the Rural Doctors Programme. I'm Jerry Gannon and thanks for your company. New mandatory notification legislation for health professionals is now in place across most of Australia and is about to be introduced in WA. And there seems to be some outstanding questions about what is required from health professionals. Dr. Olga Ward caught up with Associate Professor David Watson about the implications this legislation will have for all health professionals.
David, welcome to the program.
Thank you very much.
Mandatory reporting is about to come in the rest of Australia on July the 1st, and I guess sometime later when the legislation's passed in WA. Can you tell us about the sorts of implications you're most concerned with in medical defence for that legislation?
Well, first of all, it's not clear to us, and indeed not clear to the reporting bodies either, just quite how it's going to work. The hurdles that have to be got over are actually fairly high, so that people who report in respect of things like doctors being incapacitated by virtue of drugs or alcohol have to be sure that it's interfering with their capacity to practice medicine. And there's got to be a sort of factual test to it, so it's not just third-hand information. So it clearly implies that whoever's doing the reporting has to have observed behaviour that might threaten the public good, either the public generally or patients individually.
Now, there have been quite a lot of scary press releases, but I think particularly for country doctors, and because this legislation applies to all health professionals and not just to medical professionals, this is involving nursing staff and physios and occupational therapy and psychologists, isn't it?
At the moment there are 10 groups in healthcare that are picked up by this. That will increase again. I think it's in another year or two. Now, in theory, a nurse could report a doctor.
Yeah.
The reality is that even within our own profession, it's quite difficult for, say, you as a GP or me as a physician to really know and understand what each of us does in the course of our normal work. Therefore, to be able to say that you or I are not performing satisfactorily by virtue of the fact that we're affected by drugs or alcohol is not that easy. Yeah. Now, it becomes even more difficult when you're talking about a nurse reporting a doctor. I can think of some situations like, say, ICU or an operating room where doctors and nurses work closely together, where that might be an issue that crops up. But I think the reality is that cross-professional reporting, whilst in theory it's going to occur, is pretty unlikely.
I think the thing that country doctors perhaps are most worried about or more worried about than others are that they're often working within a very small, tight-knit healthcare team where there are other health professionals from various fields involved, but also that those health professionals are quite often their patients. And so they've got this added responsibility that the person who might be seeing them about, say, their alcohol abuse problem and their need for some treatment for that, or their problem of domestic violence or of depression or bipolar disease, is their patient as well as their work colleague, whether or not they're a doctor.
There are two things about that. One is it's not just a doctor-patient relationship, it's also a partnership, so husband and wife, similar issues. But again, one of the hurdles that has to be got over is that it has to be in the context of the practice of medicine, if we're talking about doctors. Yeah. So that on a domestic front, that's much less likely to trigger either a referral or a response from a reporting body. Now, one of the issues that concerns me a great deal is the one you raise about consultations. Yeah. And what this legislation inadvertently will do is strip away from everyone in healthcare a right that every other citizen in this country has, and that is a right to confidentiality in the consultation. At least this has the potential to strip that away. And I mean, that's the issue you're getting at. It's certainly one that concerns me. There was another one that we did take up with the Australian Medical Board and got changed. And when I say we, it was through the industry body, which is basically ourselves and Avant, and that was we employ a number of medically qualified case managers. And there was a clear implication that if one of our medically qualified case managers was looking after the incident that had been reported from a member, then in theory they would be required to report it. That has now been exempt.
Yeah.
But what we've not succeeded in doing is clarifying the issue in respect of consultations, and I think that is a potential problem.
Is that something that's likely to come before the West Australian Parliament with some modifications before they put the
Well, we'd
legislation
still like to
vote?
try. It's something that we've discussed at some length with the AMA, and they're certainly well aware of it. And I had a conversation with the registrar of our board today, and I know she's aware that the AMA is aware of it, but whether that will translate into action at the parliamentary level, I'm not quite so sure. Parliament's under some pressure to get the legislation through because, in theory, it's got to be passed before the 1st of October.
Yeah.
Or we don't get caught up in the National Registration Board. That's when the National Board goes live.
And one of the things that I was led to understand with the extra fees that we're paying for the National Board is that in some way this fee is supposed to be able to pay for the dealing with all of the extra complaints that they're anticipating that they'll receive.
Okay, the figure...
So it sounds
the
sounds
figure
quite
is
scary.
$52 million in the first year.
Yeah.
But that's not just from doctors, that's across all those 10 groups that I referred to. I think it would be fair to say that that's going to run a bloated bureaucracy because the state and territory boards will continue to exist and they'll just build another bureaucracy in Melbourne over the top of it, which is the National Board. I think everyone's been promised that they won't lose their job, which sort of worries me a bit. But I'm advised by Pam Malcolm today that in Queensland, when mandatory notification came in on January the 1st, they initially had a spike of notifications as people were getting used to the idea, but she tells me that more recently it's settled back to what they expect. That would be what I would have expected, that there'll be a spate of things coming in early while people get used to the idea. But it is a high hurdle. If you notify, you've got to be convinced that the practitioner you're notifying represents a threat to the public generally or patients in particular. And the board's not going to investigate everything that comes in. The board has to be convinced on the information that's provided that it meets that standard. If they're not convinced, they won't investigate it.
So if we had the hypothetical situation of a town which has 3 doctors, all of whom are procedural in various capacities, and one of the GPs notices that one of the other GPs is operating with very shaky hands, say under the influence of alcohol, and isn't too sure whether or not this doctor's also kind of attacking the S8 drug cupboard, what would happen? How would that reporting procedure go forward?
Well, I think we need to be clear about one point. We've always had a moral and ethical obligation to do something about colleagues who are impaired. Now, what's changed is that to do something about colleagues who might be impaired is now a requirement under a Federal Act of Parliament, as distinct from what tended to happen sometimes in the breach rather than the observance of trying to either get that individual into care or out of doing things that were dangerous. Now, in the event that someone was concerned about a colleague in a country town, I'd imagine the first thing that you'd want to do would be to talk to the individual privately. And I don't think that any of us would be under any obligation beyond that initially, even with these new provisions. Because to me, whether it's me as a physician or me an MDA, there's a collegiate thing here. And first and foremost, I want to see a colleague get help rather than, as it were, dob them in. The problem then arises if they don't do something about it. Now, you could take the example of when we introduced, when the State Parliament introduced the Medical Fitness to Drive system, which came out of an inquiry back in about 1974 or 75. And when it came in its original form, it was the first time any of us could notify a patient who was unfit to drive and not be in breach of the provisions about confidentiality. In a sense, this is the same thing.
Yeah.
And what a lot of us used to do in those days was to say to patients, you shouldn't drive because you're drinking or not taking your anticonvulsants or whatever it might be, and I'd like you to listen to what I'm saying and stop driving, and by the way, if you don't, I'll report you. And I've certainly had the experience of a number of patients then doing the right thing. I think there's a fair chance that, handled properly by people in the country, that's the likely outcome.
Yeah.
But I imagine that most people would want to look after a colleague first, and if the behaviour changes, there's no need to report.
So you wouldn't be in deep doo-doo with the board if, say, you were treating a colleague for quite severe depression, and you advise them to curtail their medical activities and have a bit of a holiday and take this treatment and see you regularly, and they complied with that, that would be fine. And you're starting to get an outcome, you wouldn't need to take it any further.
Correct. That is not a reason to notify under these provisions, because if someone is depressed, or even, let's say, in a manic phase of bipolar affective disorder, if they get effective treatment, they can be just as effective as a practitioner. They may need to take a break, but there is no way that these provisions would require that individual to be notified to the board.
Are there still going to be services like Colleague of First Contact and those other rural GP counselling services? Will there still be a place for those?
I think probably there's an even greater place, because if, as I said before, we're looking to try and make sure that people are encouraged to get help, these provisions give just that little bit of extra emphasis to get the help before someone's put in a position of having to invoke the process.
If you did have to make a mandatory report, to whom do you make the report, and how does that process work? Do you know?
Not clear. And again, this was part of the conversation I had today. I think it'll end up, whether the report goes to the Australian Medical Board in Melbourne or locally, it'll end up locally. But I can see an awful lot of red tape if all of us have to report nationally and then it gets delegated to the states and territory boards. But in the end, it has to be managed locally.
Yeah. So at the moment, the process is
not clear.
Unclear, and nobody's actually given us any directions.
Correct.
Who has access to those medical notes in that report after you've actually made a report?
In theory, it should remain like any other information in any medical board, confidential to the board.
Yep.
Now, I'm not even sure I can tell you whether, for example, in the event that someone was found to be impaired and other action was taken, like referring it to a state administrative tribunal, what would happen? I don't know. And I don't think that's clear either in the process.
I know in a small country town it's often very easy to trace a complaint. So,
yes.
You know, if a doctor made a complaint about the only other doctor containing information that only that doctor would obviously know, it wouldn't be long before the entire town knew who had made a complaint once the issue of the complaint were known.
There's no question that it is one of the real problems about rural medicine, and the only thing I'd add to it is it can occur in small, tight-knit groups in the metropolitan area as well. It's the tight-knitness of the group that constitutes the risk. And it doesn't matter whether it's Muckamboodin West or the ICU at Royal Perth, it's the same issue.
On a slightly different tack, but also to do with mandatory reporting, the other week I was going through the Health Department's compulsory education on mandatory reporting of child abuse. And I noticed that at all stages of this process, our anonymity, if we were making a report, was supposed to be guaranteed. But then in the last part of the process, when perhaps prosecution is being considered, basically anybody of a number of legal and medical bodies could decide to involve your name for making the complaint and make that public information.
I think there's little doubt that in any of these mandatory reporting things, in the event that there was to be litigation, it's hard to stop anyone who was the trigger, that is the notifier, from having their name published. It's almost inconceivable that the courts would permit that.
And what's the situation for those of us who have trainees or registrars in the practice? If they're impaired, does one go through an additional layer, like involving the training organisation, or is this just something that's got very clear steps that
Look, I think that
go through?
for all of us who are engaged in post-graduation training, it's an issue, even before mandatory reporting. And it's the same moral and ethical obligation to look after a colleague. And for you or anyone else with, say, rural GP trainees, first and foremost, the emphasis has to be on helping that individual. I mean, I've got a couple of junior staff here where we're doing just that, and they've had time off to get help for their medical and psychological problems. And when they're cleared by their doctors, they'll come back, but not until then. And I think the same would apply to any of your GP trainees. I certainly wouldn't be threatening them with reporting. Obviously, if they are unwell, the training body has to know about it, but I imagine that would be kept confidential. And I'd hope that, unlike the old days of nursing, where if a nurse made a drug error, it appeared on her employment record, that in the context of trainees, developing an illness, be it profound depression or leukemia through training, remains entirely separate from their training.
And David, finally, you've talked about rehabilitation and reinstatement and whatever. How would that process be thought through in the context of this mandatory reporting?
I don't think that's clear either, and I can tell you that where we've tried to do that in Western Australia, say with a surgeon, it's extraordinarily difficult. In the old days, the public hospitals would allow people to come back in and do a number of procedures. These days, the public hospitals seem less and less willing to do it. We've engaged colleagues within MDA to try and support individuals getting back into practice. It's very difficult. And one of the issues which remains unresolved, at least in this state, is if someone's engaged in mentoring someone back into practice at the request of the board, our view is that the board carries the responsibility of indemnifying the individuals involved. The board has an entirely different view.
Well, David, I guess this is going to be watch this space for the next few months. Will there be some information coming out from Medical Defence or from the local medical board to update the doctors as it all happens?
We've already put stuff around to members. The board sent some stuff around as well. I imagine, and again by inference from the conversation with Pam Malcolm today, they will continue to do that. The National Board has put out some draft guidelines which are available on the web. They're still in the process of being finalised. I'm sure we're going to get bombarded with stuff on our emails and elsewhere.
Yeah, because most of the email and other information has been, I guess, as you say, very non-specific.
Yeah.
What happens if it's not decided by October the 1st?
I don't know. I honestly don't know. There are a couple of states where the legislation hasn't gone through to support the national legislation. I can't imagine that 6,000 doctors in Western Australia would find themselves deregistered.
Thanks very much for being with us today, and would you be willing to come back and talk to us again, perhaps when the legislation's been passed and maybe when some of the wrinkles have been ironed out or found out with the practice in other states?
I'd be delighted, and there may be a lot more to talk about.
Terrific. Well, we'll look forward to that. Thank you.
Pleasure.
And a big thank you to Associate Professor David Watson for joining us. If you'd like any further information, you can download the guidelines on mandatory notification from the Medical Board of Australia at www.medicalboard.gov.au or contact your indemnity provider. Thanks for taking the time to join us on this special webcast of the Rural Doctors Programme.